Hello, and thank you for joining us this afternoon. My name is Alexis Smith, and I am the International Partnerships and Programs Coordinator for the Office of International Programs at KUMC. This is the final 2020-2021 Foundations of Global Health presentation, and we're glad you're able to join us. Is a varied and exciting field to which many healthcare providers, researchers, and faculty aspire to being professionally engaged. With our being a globally connected world and with COVID-19 uniting the world to solve an issue, global health has never been more relevant. This year-long programming is designed to feature our experts in the field of global health, KUMC's faculty, researchers, and clinicians, our international partners, and our community partners. Each presenter will share their personal journey, educational background, mentors, books, and articles that gave inspiration, challenges, lessons learned, successes, epiphanies, life-changing moments, and the heartbreaks. We have some objectives for our series. The learner will gain foundational information on pathways into global health and will be challenged to deepen knowledge on equality and mutualism, which garners true collaboration and global health exchange for everyone's equal benefit. The learner will examine existing attitudes around global health so that we at the University of Kansas Medical Center are trendsetters who move beyond the us versus them, haves versus have not mentality. The learner will be able to appraise global health, including global health research, philosophy, approaches, attitudes, and the varied efforts in the areas of health disparities, health inequalities, and community health. Again, this is our final 2020-2021 presentation, but we are currently scheduling for the upcoming academic year, so be on the lookout for that. About our presenter. Dr. Nicholas Comninellis. Dr. Nicholas Comninellis is Dean and President of INMED, the Institute for International Medicine. He is also faculty in the Department of Medical Humanities at the University of Missouri, Kansas City, UMKC, School of Medicine, and faculty at Research Medical Center Family Medicine Residency. Over 2 years, Dr. Comninellis served inner city citizens at Shanghai Charity Hospital. Over another 2 years, he led a healthcare ministry in the war-besieged nation of Angola in Southern Africa. Dr. Comninellis served for 6 years in the Kansas City Public Hospital before launching INMED in 2003. Dr. Comninellis studied tropical medicine from the Walter Reed Army Institute of Research and became board certified in both public health and family medicine. He was recognized as the 2009 United Nations Association of the United States World Citizen and the 2015 University of Missouri Kansas City Alumni of the Year. And now I will turn it over to Dr. Comninellis.
One of the elements of the last year and a half has been the dual challenge of dealing with a disease that was not known before. At the same time, we're trying to control a disease. So we're studying and we're also intervening. But early on, one of the clear lessons from the COVID pandemic is that this is one disease that especially affects people who are vulnerable. The poor, the elderly, the marginalized, low income, wherever they may be in the world. Now, I'm especially interested in people like that. It began as a medical student. I spent 2 months as a senior med student at the Clínica Evangélica Morava on the eastern coast of Honduras. And there, shortly after I arrived, there was a little girl, a little 5-year-old brought in with a fever. And she had a convulsion right there on the exam table. And of course, I was scared and parents were scared. And my mentor came in the room and he said, "What do you think's wrong with this girl?" And I said, ear infection, febrile seizure. And he shook his head and he said, "What do they teach you in medical school nowadays?" And so we took a drop of blood and we looked at it under the microscope, and she had the ring-formed parasites of malaria in her blood cells. Well, that plus a seizure means she has cerebral malaria. Kills about 20% of people. Well, this girl survived. And I began to think, wow, I want to do this kind of work, but I've got a lot to learn. And so as a resident physician, I worked in Burkina Faso, West Africa, for a couple of months. Now, why Burkina? Because Burkina Faso is the poorest nation in the entire world. And that's where I wanted to go. And so soon after I arrived, I saw this child with these lumps on his head. And these are a little warm and a little tender and a little squishy. And so I thought, what does this child have? What do you think this child has? Warm, tender, squishy? What could that possibly be? Well, I thought it was an abscess, right? So I numbed up the kid and I incised that lump, and what came out? It wasn't pus. It was a big white worm. It was onchocerciasis, better known as river blindness, which causes kidney failure and scarring of the retina. And again, I thought, oh man, I've got so much to learn if I'm going to do this kind of work. So I graduated and I moved to Shanghai, China. Shanghai at that time was a developing country. Our leading diagnoses were tuberculosis, schistosomiasis, and rheumatic fever. Now, of course, China has developed since then, but there are still pockets of low-income people, just like there are in every nation. I finished my assignment in China and I moved to Angola in Southern Africa. Why Angola? Because it had the longest running civil war in African history. 40 years they had been fighting. It was a nation with no schools, money was worthless, and more landmines per capita than any other nation in the world. For every one of these children, there were 11 landmines planted. And no surprise, it was a nation of amputees. Well, let's fast forward to today. What has COVID done to the world's most vulnerable people? Well, I want to begin that from the perspective of Angola. So this is me last summer standing outside the entrance of our hospital. First thing that it did was it caused a complete wipeout of our staff. Half of our staff were either ill from COVID or too elderly to be at risk for coming in. At the same time, our patient load doubled. So this is our pediatrics ward. All right, so these are children and their mothers. Most of them are here because of an acute fever. They have fever and they're crowded in this room. What do you suppose would cause acute fever in children in Southern Africa? Now I'm watching the chat, and so if you have a reply, please type it in the chat, and I'll be watching for it. Okay, fever, acute illness, Southern Africa. So I'll give you a hint. Many of these children have the leading cause of death in the low-income world. What is the leading cause of death in the low-income world? It's pneumonia. Now, could some of these children have COVID? Well, great question. We have no COVID testing. This is a nation where most people earn about $1 a day. And so the ability to provide modern healthcare is very, very low. Another big takeaway from the COVID pandemic has been this close influence between health status and other institutions within a society. Our schools, our jobs, our government, our transportation, which brings us to the WHO definition of health. A complete state of physical, emotional, and social well-being, not just the absence of disease. Now, what do you think of that? Is that a useful definition? Well, I still think it's a bit utopian, but it does point out that critical connection between health status and other social institutions. There is no country in the world that has wonderful physical health and a terrible economy or terrible school or deficient government, and they all rise and fall together. At InMed, we use the Human Development Index, the HDI, and this is a system that is used throughout the WHO and the United Nations programs, and it assesses human well-being using just 3 criteria. There is longevity, how long do people live? Knowledge, how much education do they have? And income, how much money do they make? And the reason these 3 parameters were chosen is because you can put a number on them easily, and you can watch them rise and fall. And so let's look at COVID in the developing world from the perspective of the Human Development Index. So if we look at health status over the last year, this was taken in December. Red represents countries that have infection, and the size of the bubble represents how much infection there is. And so you notice that North America and Europe have lots of red, but then there are parts of Asia and Africa where there doesn't seem to be much infection. Now, why is that? Well, it could be because the population is sparse. It could also be because in cases of Angola, we simply do not have any testing available in order to make such diagnoses. In fact, we hardly have a chest X-ray, let alone anything more advanced than that to make a diagnosis. From the perspective of infection during the pandemic, the brown color represents countries where schools were closed for part of the year. Red is countries where they closed the school for essentially the entire year, and blue was largely unaffected. So the impact of education has been profound. And you've heard educators speak about this being the lost year in education. Similarly, the impact on economics has also been profound. In the brown are countries where GDP dropped by at least 10%. Dark brown by at least 20%, green relatively unaffected. So most of the world took a huge economic hit during the pandemic. A couple of other really important lessons from this has been the importance of cooperation. So we have a disease that affects multiple countries where interaction between them, information sharing with them, designing interventions and cooperation with them is essential in order to control it. We haven't always seen that actually happen, though. An even more disturbing outcome from this has been blaming, has been identifying a particular race or a particular country as being the culprits for this problem. Just this week, the WHO introduced a new system for naming the strains of COVID. Rather than call it the UK variant, for example, they're calling it alpha and beta and epsilon and delta to give it a name that is not connected with a particular people in order to diminish some of the really evil consequences of this naming and blaming that have been going on. I'm a follower of Christ. Personally, I'm inspired by the life of Christ in which he intentionally sought out people who were on the margins, the poor, the lame, the outcasts, the prostitutes. He tells this account of a man who was traveling from one city to another and was brutally beaten by thieves who left him for dead. Well, what happened? A religious man walked by and noticed him and just kept on going. A civic leader walked by, noticed the man bleeding out on the ground, and well, he didn't have time for that, and he kept on going. And then came along a lowly foreigner who saw the man and had compassion on him, who treated his wounds, who transported him and paid for his rehabilitation. This is a timeless model for us today. And so what does the next year look like in global health? Well, I want to answer that question from the perspective of the Human Development Index. So let's quickly touch on each of these. Let's start with education. There is a close connection between people's education status and their health status. Even when you control for their economy, for the age distribution of their populations, some of the best research on this comes from Tanzania. On the horizontal axis, we have years of formal education, 4 years, 6 years, 8 years. And on the vertical axis, we have the risk of death, the death rate, the chance of dying in any given year. And so in the lower right corner are people who are highly educated and who have a low death rate, 1% for people who have 10 years of education. By contrast, in the upper left corner, there are those with low education and a death rate that's at least twice as high. Why is it that death rate and education are so closely connected? Now, some of you might say, well, gosh, I'm a healthcare professional. I'm not an educator. And I understand this may not be your expertise, but our objective is to improve people's health, not simply practice our profession. And so we need to be familiar with what it is that actually does improve people's health. And if education is one of those, then we need to step up our game and understand education. What can we do as healthcare professionals to promote people's education status? Well, for example, you're examining preschoolers and you're talking with their mom. It's an opportunity to encourage parents to read to their children, help their children understand the value of education, the value of reading. You're talking with a teenager in a clinic setting who is uncertain about their future. And so you can say a word of encouragement to stay in school, to graduate, to develop a plan. Your kind of role modeling and tactful words can be very influential on that person. Now, what we've done in Angola in the area of education is literacy training. This is our classroom at the hospital. We open it up at 4 p.m. every day, and people from the community can come in and learn to read and write. Now, this is a huge thing for someone who's in their 30s or 40s to finally get some formal education. You can imagine what it does for their sense of well-being and what it does for their employment prospects that they have this new skill. Now, what do you think of this question? All of the following are true about the connection between health and general education, except one. Which one's not true? So as education years increase, mortality decreases. It's an inverse relationship, actually. The second part of HDI is income. The connection between poverty or income status and health status is extremely close. The very best book I've read on this subject is The End of Poverty by Jeffrey Sachs. Now, Sachs is a Columbia University economist, but his wife is a pediatrician. And many of the stories, examples in The End of Poverty come from the world of health. It's a great read for a non-economist like you and I. And Dr. Sachs explains that for the lowest income communities that are largely agrarian based, what they need is modern seeds, modern fertilizers, modern farming techniques. And then as food production increases, then there's more capacity to diversify, to go into manufacturing, into service kind of industries. What do you think of this image? What's going on in this photo? Who are these people and what are they doing? Some of you have seen things like this before. So these women are waiting for water, delivery of water, and who's with them? Lots of children. Don't these people have something better they could be doing? Shouldn't these children be in school? Don't these women have something more pressing? And so the provision of water for domestic use is essential, not simply to prevent diarrhea diseases, but also so that children can go to school, so that women can start businesses. What we've done in Angola to address the water issue is to install deep wells. Angola is a very rich country agriculturally. You can take a spade and dig down 20 feet and hit water anywhere in the nation. But that water may be contaminated. And so these are 150-foot deep wells where the water that you pump out is drinkable without any further chlorination or filtering. And so we've installed about 12 of these in the community where our hospital is located. And as a result, children can go to school. Women are starting businesses. What can you and I do for economic development? Well, there again, I'm a healthcare professional. I'm not an economist. True, but you have an opportunity to encourage people to stay at their job, to find a better job. If they are seeing you in a clinic setting and they need a work excuse, give them a work excuse. It would be a travesty if because of their physical illness, they lost their job. We do what we can to support people's economics. And then the third element is a long life expectancy. Oh, now sigh of relief, now we're into healthcare, especially on behalf of the world's lowest income communities in the bright colors on this image. Now, it's a big world. Where do you possibly begin? Well, one way to prioritize world health problems is to look at the leading causes of life years lost. Now, this is a very important term, the life year lost. And let me illustrate. If a child dies of pneumonia soon after birth, how many deaths is that? It's one tragic death. If a 90-year-old dies of heart failure, how many deaths is that? It's one death. But that person, bless their soul, has already lived beyond the life expectancy for most people. And so what life years lost does is it takes into account not only what causes the death, but how old were they when they died. And so if you look at the world's 50 lowest income countries and ask, what are the leading causes of life years lost? It looks like this. Now, what do these have in common? Almost all of these diseases have a common connection. They're mostly diseases of children. In the North America, we think of pneumonia as the old person's friend, as the cause, but in the developing world, pneumonia is what kills children by far. And so when we address our health priorities, this gives us some quantitative way of saying which is the most efficient use of our limited resources. Now, behind every cause of death, there are risk factors. Risk factors are important because those are our points of intervention. If we can address the risk factors, reduce the risk factors, then we can reduce the causes of death. And so if you look at these and you say, wow, what are the leading risk factors for these diseases? What comes to mind? Someone is more likely to develop or die from pneumonia, malaria, diarrhea, etc., if they have what? So the leading risk factor is malnutrition. It's being underweight, followed by unsafe drinking water, unsafe sex, Indoor smoke from solid fuel. What is that? Well, I think some of you have seen this before. In many other cultures, the cooking fire is inside the house. And so the house is filled with smoke, and the people in the house are breathing the smoke, and they develop COPD just like a smoker does. Big cause of risk factor for respiratory illnesses. Now, what do you think of this question? Each of the following is a leading risk factor for life years lost in low-income nations, except which one? And you are correct. It is hyperlipidemia. Now, is it because they don't have hyperlipidemia in low-income countries? No. Generally, there's just as much hyperlipidemia there as there is in North America or Europe. It's just that the complications of hyperlipidemia kill people in their 50s and 60s and 70s. Whereas in lower income countries, people are more likely to die of an infectious disease before living long enough to die of a complication from hyperlipidemia. And so with these risk factors in mind, what would be the highest priority interventions in the world's lowest income countries? Now, we're talking in broad strokes here, but if you were going to an ultra low income community, first of all, once you arrive, you would go door to door, you would do a survey, you would collect information to find out the needs of that particular community. But in broad strokes, your highest priority interventions are going to be focused on those leading risk factors. And so nutrition, drinking water, reproductive health, vaccination, injury prevention, well child care, pregnant woman care are going to be probably the highest interventions, the highest efficiency things that you could do in cooperation with a community to improve their overall health status. Now, in Angola, what we have done to address healthcare manpower is to create a residency program for physicians and a postgraduate program for new nurses. Now, this is a country where there are no residency programs. People graduate from medical school, usually never having actually written orders or cared for a patient themselves, and they're given the title doctor, and there's no further training, and they're free to go practice. Is that a good idea? That's a pretty dangerous idea. And so what we've created in Angola is a 2-year program for new physicians to come work with our gray-haired faculty and see how it's done. Similarly, with our nursing grads, they come right out of school, again, with usually no actual hands-on clinical experience. It's observational, in much of the developing world. You just, the students watch, they don't do. And so they stay with us for a year, and they go through a supervised introduction to patient care under the mentorship of an experienced nurse. And so in this way, what we're doing in Angola is to expand our manpower, woman power, so that the graduates are able to go and serve in other locations. And at some point, some of our faculty are going to retire, and there'll be people skilled to continue the work there. Now, it's a really big world. Where can we possibly begin? Now, I'm kind of a visionary person. I think big. I think many of you are that way as well. And it's for this reason that 18 years ago, we started the Institute for International Medicine with the idea of giving healthcare professionals the special kind of skill that they need to be successful in serving the world's most marginalized. Our biggest event of the year is the Humanitarian Health Conference. It actually is a week from tomorrow here in Kansas City. This event is going to be both in person and virtual. So if you register, you can walk in the door. We're located near the Arrowhead Stadium Sports Complex in East Kansas City, or you can log in and watch the sessions online. The student code is student 20. That gets you in for $20, students. I put the link to the conference in the chat. Right at the beginning of our chat is the link to the conference. So consider joining us next Friday. We also offer professional certificate courses in international nursing, international medicine, public health, diseases of poverty, cross-cultural skills, healthcare ethics, health professions education, disaster management, refugee care. There's about 15 courses currently available. And then with that kind of didactic background, you're ready for an international rotation. We have training sites in 25 nations where we have faculty who live on site who are really interested in supervising you for a clinical experience. Now, some of these are taken advantage of by medical students or nursing students, resident physicians. And then we have people who are already in practice who say, I'm really interested in serving, but I don't want to just go out there on my own. I want someone to introduce me to this kind of work. The power of a supervised internship, a supervised learning experience is especially powerful. And then we recognize our graduates with a professional diploma in international nursing or international medicine or international public health. And then for those who want even more, we offer the master's degree in international health, the MIH, which takes those elements and adds to it epidemiology and a scholarly project. Now, these are credentials. What they mean is that you not only have a good heart, but you've backed it up with some diligent study and some actual field experience. I'm going to wrap up in a moment and I'm going to open it up, and I'd like to know what kind of comments, what kind of experiences you would like to share with this distinguished group. One of the things that we have learned coming out of the COVID epidemic in the United States is that no one is safe until everyone's safe. You know, there's still disease around the world. And so please join with me as we continue to work to make everyone safe.
Great job. Thank you, Dr. Comninellis. You always present such interesting information and really relevant. I appreciate the additional COVID information. I think that's very interesting for everyone. I'd like to ask individuals if they have questions, please feel free to unmute yourself and just join in. We can now just have a little casual chat amongst us. And if anybody has any comments, or questions, please, again, just unmute yourself. This is very, very casual, and no need to go through us for your questions. Dr. Comninellis, you mentioned education being impacted around the globe due to COVID-19. What are you hearing in terms of your connections and your professional organizations in terms of what the long-term impact may be of this lost year of education?
Well, I think that time will tell. Of course, educators were all concerned about all of this. I think in terms of healthcare professionals, young healthcare profession students who graduated last year, who had kind of an abbreviated clinical experience, these are generally very bright people. And it might take them a few extra months to get up to speed, but I have no doubt that they will. We tend to work with altruistic, diligent students who I'm sure will catch up, no doubt.
Do you think that kind of to connect to that point, COVID-19 and it being a global pandemic, something none of us have ever experienced before, what do you think the influence that will have on individuals' decisions to go into healthcare, to be a healthcare provider, maybe even more specifically to engage globally in global healthcare. And what are your thoughts on that? And I know I'm putting you on the spot. This is, you know, like reading the crystal ball that none of us have had this past year.
Sure. Well, of course, this will be a wonderful subject of research, you know, moving forward. And I think that there are those who are not in healthcare yet, who will look at all of this and they'll go, oh my gosh, that's too intense for me. I think I'll go into something else, you know. But then there will also be others like my nephew's wife, who's like, oh man, this is wonderful. I want to do everything I can for humanity. You know, I'm going to nursing school right now. I want to get in there and help people. And so, yeah, it sort of divides people maybe in both directions.
What about the impact on actual travel? I know that InMed has, you know, utilized and leveraged the virtual platform, you know, for a long time. What do you see in terms of impact on global health collaborations and interactions relative to place-based versus the virtual, maybe telehealth or collaborations? Have you thought about that at all, or have you seen any trends in that?
The telehealth, you know, technologies, of course, are much more mainstream than they were a year ago. And
Right.
I see that rollout in Angola. There is talk of creating a virtual medical school, which you know, has got some challenges.
Interesting.
You can communicate knowledge that way, but not necessarily judgment and skill. So it would have to be married with some of those elements, you know, in order to be successful. But yes, I think a big takeaway from this has been how much of our traditional in-person can be, you know, supplanted, or when necessary, by virtual kind of platforms like we're doing right this moment.
We certainly have seen the benefit of speakers and being able to, like what you just said, like just share information, have joint lectures and presentations that span the globe. I know Dr. Adu has been able to join from Ghana. And of course, it just wasn't, it's not that we didn't have the technology before. I think we didn't have the habit, because we offered our presentations by Zoom for a couple of years prior to the pandemic, but just people didn't really take advantage of that. It was something we set up. It was something we promoted. We would have, I don't know, Alexa, maybe 2 people, maybe a few people from like our Salina or Wichita, maybe up to 5. Yeah. But it wasn't something, I think it was more of a habit that a person who could attend in person, they just weren't, you know, used to leveraging that technology.
Right.
So we certainly have seen that benefit. We've really enjoyed being able to welcome our partners like Dr. Adu, some of his colleagues from CAF in Ghana. We've also had some of Dr. Kovac's contacts in Peru join. And what's interesting about that is, at the end of the day, it's technology and relationships that leverage people and encourage that joining, because those are the individuals we've seen participate. So before we had the technology, people didn't really use it. Now we have people are used to the technology, and then the real impetus, I think, has been the relationship.
Yes. Yeah, I agree with you that we were able to, well, for example, the InMed virtual conference, well, now we can have all of these 40 training sites in 25 countries, you know, they can log in, they don't even have to worry about getting a visa. So I'm sure they would love to come in person, but in terms of logistics, you know, this is a whole lot more accessible.
Yeah, that's wonderful that you get people from your 40 training sites. And when you think about logistics, but also cost, that's incredible to be able to leverage that.
Right. Yeah.
Hello, Nicholas.
Hi, Tony.
It's good to see you. I always enjoy your presentations, and it's always interesting to me to see the young Nicholas from years back when you were in China and Latin America. But I guess I have two questions to, you know, with your different sites that you have now all over the world, and as perhaps different parts of the world is responding to COVID in various ways, and some being more vaccinated versus others. What are you recommending or to people now for next year about when to go to different areas or parts of the world? Will it be a point in which a certain percentage of their population is vaccinated, and the number of cases is low? How will you deal with that?
So Tony, it's a moving target. We have a full-time staff person who all she does is just work on international rotations and placements. And so it's multifactorial. For example, we work with a training site on an island north of Honduras. COVID has not been a problem on the island. Transportation in and out of the island has not been a problem. And so we're sending people to Roatan for their clinical rotations. By contrast, we also have a number of training sites in India. Now is not a good time to go to India. And so we're not scheduling for India. And so it's really nation by nation, with the caveat that plans may have to change as COVID or other factors come and go.
I'd like to add on to that, Dr. Kovac. It's something that, we are tracking daily. Not only do KUMC individuals register their travel with us for professional travel, but it's now also personal travel where they're encouraged to register. So we're following KDHE and CDC daily, and Stacy creates communications so that people are aware of, what obstacles they may run into just for entry into a country, for example. Right now, a lot of countries are not allowing US citizens entry, or they're allowing entry with quarantine. So it's very, like Dr. Comninellis alluded to, it's varied and it's ever changing. And we do hope with the increase of vaccination rates that we'll see some changes, but positive changes. But we also know that some of the countries that are have low infection rates might also have low vaccination rates. And so, for example, Thailand is a level 2 today, but we don't know what might happen in November. It may end up being an issue like India, where there's an explosion of infection just because the vaccination rates are not high enough to prevent that. So it's really fascinating to watch this and track it. And I would say planning our 4th year rotations for February is like it's never been before. It's interesting is the word, maybe not the appropriate word. It's very chaotic, and we don't have some of the definitives that we like to have.
I just have one more question, Nicholas. I was wondering, what's at the different sites around the world that you're at, and with Zoom, if let's say there's a medical question that comes up, will the doctors, in Africa or Latin America or India, would they maybe contact you or specialists in Kansas City, let's say at Research or UMKC, to get a virtual Zoom consultation? Is that in use, or do you do that?
We've actually been doing that from Angola for 20 years. Our facility in Angola, we have a radiologist and we have a dermatologist in the US, and pathologist. that we send things to and we ask questions of. And of course, now we're starting to use FaceTime more, where we're actually seeing the patient and we FaceTime our consultant and we do the interview together. And so it's a phenomenon that has always existed, but I think now it's even more so, more accepted, more mainstream.
Well, I look forward to attending the conference next week.
Yeah, thank you, Tony. I appreciate that. Rebecca, I'm reading your message here. Would you like to say it out loud for everyone?
Yeah, sure. I was just wondering because in some of the conversations that I've had, I have friends that live in the Netherlands. We've lived in Mexico ourselves and have friends there. And just also my daughter was in South Korea actually when COVID broke out originally, actually. And so these are just thoughts that kind of we have tossed around and been thinking about. And I was wondering what some of your thoughts were on that as far as this global connection that we have, an international community that we're trying to develop more so. Maybe we can also learn from other countries as well as what they're doing because they have much lower infection rates. They haven't had as nearly the problem that we've had. And one of the things we say is because, we're more free thinking, we're more independent. And maybe I'm seeing it too simplistically. So I was just kind of wondering what your thoughts were on that as I've discussed this with other people in other countries. They're natives. They live there, they're born there. And the idea for us as a country to be maybe more education on being more considerate or more selfless sometimes to try to, just tactfully phrase that. But, everyone has the right to their own thoughts and their opinions and their beliefs for sure. But just as far as education to understand that what we do does really have an impact while remaining free and while, keeping that independence, or other thoughts that maybe or insights you have into that maybe it's caused their infection rates to be so low.
Right. I think, Rebecca, all of us are to a degree students of the human race. We're watching what's going on in the world and we're trying to make assessments. And certainly there are some cultures that are much more individualistic, much more confrontational, than others. I think the United States is probably pretty high on that ranking. By contrast, I have some experience in Taiwan. I speak Mandarin, and
Cool.
my interaction with Taiwanese is they are pretty cooperative people. They seem to have a pretty strong sense of unity in their communities, and maybe not quite as divisive as we have been in North America. And they have, of course, a much lower infection rate, death toll, everything, in terms of COVID. And I believe it would be because they're a whole lot more willing to follow instructions, cooperate with one another, preserve their sense of unity.
Right. I was just wondering if there's maybe other things as well, because with my daughter living in South Korea, was it, possibly some education? Was it possibly, just, other factors that maybe we weren't thinking of, or was it certain regulations that they put in place faster, just things like that maybe we could learn from that maybe I wasn't hearing. I mean, I do have, because I've tried to be very connected, I had students that had come over and, we're good friends. They've gone back to Taiwan now, and things like that, and just discussing with them. And they were saying, yes, we had a lot of things in place, and because we'd already had this happen, and just things that we could learn, for the future. Because this could happen again. I think that's kind of in everybody's mind. And how could we handle it more proactively, maybe?
Yeah, I agree with you. Hopefully one of the takeaways from all of this will be a greater sense of anticipation of problems, of building resilience, of monitoring early detection of infections and other things. Our next time around, we'll do better, I hope.
Right. Totally. Yes. Thank you.
Yeah.
Hello, Dr. Nicholas.
Hello.
How are you?
Good. Good.
Thank you so much for your nice and interesting presentation. I enjoy a lot. I am a grad student of nutrition and dietetics. So the only thing which, came in my mind is, do you think is there any kind of nutrition intervention which you can introduce or apply, during the COVID? Like help people, or no, is not kind of related in any ways, based on your experience. I just wondering, do you think is there any nutrition intervention to address or help people for dealing with this situation?
Mhm.
Or no, all is about kind of vaccine, medical intervention, or something else? Thank you.
Yeah, thanks for asking. I mean, I think that the simplest correlation is just between protein calorie malnutrition and risk of death. And so a child or an adult who has baseline protein calorie malnutrition is going to have impaired immunity and an impaired response to a COVID infection or other acute respiratory illness. Is there a trace element, for example? Is there a micronutrient that is connected with risk of COVID? Not that I'm aware of. There may be, but I think it mainly comes down to just protein and calories. Are you aware of any particular micronutrient that is a factor?
This day we heard a lot about different nutrition, kind of, conventional wisdom based on, just people we heard, especially, in the probably Eastern culture in the Middle East, China, every single day we heard different nutrition intervention, just based on conventional wisdom or, just based on people recommendation, which is, is getting more and more popular in this culture. So I was curious, if you heard or, do any survey research in this regard. For example, in my country, every day people are, recommending, advising different nutrition intervention, taking different kind of, herbs, I don't know, different, traditional kind of, medicine to, to kind of boost the immune system, or, which sometimes there are even dangerous or, in opposite to the real treatment. But, in probably Middle East countries, they are so popular, people believe to this kind of treatment. Even, for example, in China, Korea, they are, trust to this kind of treatment, even sometimes more than vaccine, that is undeniable, I guess. So as you said, you are connecting with this culture, and you have a different agencies, expert who are working or facing to this situation. I was wondering if you have, or you are working on kind of, educating people in this specific area, or, introducing other alternative treatment or something.
In terms of nutritional intervention, no, I'm not aware of anything that has actually been shown effective. There certainly is some research questions going on out there, and maybe we'll learn of something, but I'm not aware, and I'm not involved in that in particular. I did want to ask Dr. Adu if you have a comment you'd like to make about this.
First, I would like to thank you for your presentation. It's been very deep. I always appreciate people who come over and understand the culture and have a long-lasting impact through education, like you said. So just like Amin said, in Ghana, we've had a lot of, people talk about some herbs and things to take, some spices that when you put in food helps to increase or boost your immunity. And like Amin said, some of these things, those who believe these things would prefer to have those interventions that are local and traditional as against going for the vaccines. Yes. So, but medically, I also have not, most of these have not been proven or accepted by the Food and Drugs Board or anything. Yeah. But we have all sorts of traditional methods that have come up and been bandied around.
I have a quick question, specifically, like more specific to just the InMed program itself. I also just want to thank you on your presentation, Dr. Comninellis. That was very insightful. I was like, through your presentation, I saw that InMed did a lot of like pretty holistic stuff in the countries that it's working in, like installing the deep wells and doing more of like an educational approach. And I was wondering, like the volunteers that get involved with InMed from like a healthcare perspective or coming from a healthcare background, are like, do they get a chance to work in like the educational realm, or like more of like the infrastructure realm, or is it just more like solely focused on going and providing care and like learning from like the local healthcare workers in those nations? Or is it more of like a holistic approach? Would everybody be working on the whole picture?
Luke, thanks for asking, and I appreciate your compliment. The reason we have so many different training sites is because we want to provide a spectrum of opportunities. These are service learning. You will be learning at the same time you're serving and you're being supervised. And so some people want to do orthopedics and trauma. And so we'll send them to a facility that does lots of orthopedics and trauma. Some people want to do community development and literacy. And so we'll send them to, we call them training sites, a training site that is primarily involved in those kind of activities. So you tell us what your particular interest is, and then we'll try to set you up with an experience that matches that.
Perfect. Thank you.
And we realize that you're only going to be there for 4 weeks, 8 weeks. These are all health facilities that function year-round, with or without you. They are carrying on, and so whenever you come, you are there essentially as a learner to be involved in whatever particular care you have selected, from the standpoint of them sharing with you, their knowledge and experience, and you being able to build some capacity as a result.
Yeah, that sounds like an amazing experience.
Thank you for reiterating that, Dr. Comninellis, that our students go as learners and to learn in that environment, which certainly is different. It could be quite different than learning at KU Med or in some of our other partner clinics here in the United States. So there's a lot to learn. There's the culture, there's the difference in healthcare systems, there's whatever that individual mentor doctor has, that system. So it's probably a little overwhelming, I imagine, as a whether it's a medical student, nursing student, dietetic student. We've had our dietetic students go to India. Actually, it's probably a lot to absorb in such a short period of time. But we do think that the experience is like the beginning of more experiences, and hopefully the beginning of collaborative relationships, connections to people that would motivate our students and our future healthcare providers to want to engage more in the future. Sorry for the airplane overhead. That was really loud. Dr. Comninellis, as a pilot, that might be the sign that it's time for you to fly away. It's time for you to, I want to be respectful of your day. You're so generous with us with so much going on. I just certainly appreciate your time. And I'd also, if you don't mind, Dr. Comninellis, like to offer, you're very generous with your time with our students. And I know that if any of them have interest in any of your programs, your certificate program, you're always, your master's, you're always willing to chat about that. So.
Yeah, certainly be happy to continue the conversation. My email is in the chat. So if you'd like to take that down, let's stay in touch. Okay.
And if a student wants to use one of your sites for their M4 rotation, Luke, for example, like you might want to do the certificate program and then complete it at an NMed site, we coordinate with NMed on that. So you get both credit at KU for that rotation and you get credit for the NMed certificate. And we've had students do that. It's been quite successful. Great opportunity.
Excuse me, Dr. Nicholas, can I ask to make sure how we can apply officially for kind of opportunity, a kind of volunteering opportunity during the summer? Is there any such opportunity?
Yes, there is. Would you please message me? I put my email in the chat.
Awesome. Yes,
and
sure.
I'll just send that to you.
Awesome. Awesome. Thank you.
Thank
Of
you.
course. Thank you. Great.
Well, thank all of you for logging in, and I sure enjoyed talking with you today. And special thanks to Kimberly and Stacy, Alexa, for setting all of this up. And it's been a wonderful series. I've sure enjoyed following it all springtime long. It's really been great.
Thank you, Dr. Comninellis. Thank you for that. Appreciate you. Bye, everyone. Thank you for joining today.
Bye,
Thank
everybody.
you.
Thank you.
Good to see everyone.
It was great.
Bye, Dr. Adu, Dr. Kovac.
Bye-bye. Thank you.
Thanks, Alexa. Thanks, Stacy.